Hello, everyone. So, welcome back to another session of ICB-SC webinar series. We are really delighted to have Dr. Ahmed Metwali as a keynote speaker for this series. Dr. Ahmed is right now a senior bioinformatics scientist at Illumina AI Lab in San Francisco, and he has been working as a postdoctoral scholar in Snyder Lab at Stanford University as well. Ahmed received his PhD in bioinformatics and MS in computer science from University of Illinois at Chicago. And right now, in his postdoctoral research, he has been working on developing novel machine learning methods for longitudinal multimodal biomedical data to early detect cardiometabolic diseases and personalize their treatments. He will be discussing this research in today's webinar session. So I will pass on the mic to Dr. Ahmed and let him take over with his talk.
Sure, yeah. Thank you so much, Sayan, and thanks for the invitation. It's always a pleasure to speak with ICB Student Council. For this talk, it's kind of, I'm not sure if it's like someone has talked about this before or not, but it's kind of new domain in omics, which is wearables. And how can we enrich all different multi-omics by adding a new ohm to it, which is wearables. The good thing in wearables is that we can measure lots of physiological parameters in it. And I really believe that this is the future of personalized medicine. If we really want to understand what's happening at the molecular level by doing different omics assays like genomics, transcriptomics, proteomics, metabolomics, and all of these. But we also want to have a good phenotyping, real time, and also continuously monitoring people. So wearables offer that perspective of the data that can be correlated with anything that's happening during the health and disease. And for today, I will be talking mostly about one use case, which is COVID-19, and how we use wearables to be able to detect COVID-19 early before symptoms actually happen. So I will start with just a very brief introduction about wearables. There are so many different wearables. And when I talk about wearables, those are, like the smartwatches that many of you wear, CGMs, like continuous glucose monitoring, things like batches that measure AKG, and many others. And there are like around like 900, maybe thousands of these nowadays. And I would say with every day, you would see lots of those wearables in the market. There are a couple of different types of wearables here. There are rigid wearables, and those are like the watches that we have, but there are also stretchable wearables. And those are things that kind of flexible electronics that you can put in your, like on your skin, and they can take some biofluids like things from the sweat, and then they can extract some molecules like cortisol, and then they can measure, like you have an actual continuous measurement of what's going on in your body real time. So again, what I'm going to talk about today is mostly about rigid wearables, and I'm talking about consumer grade wearables, things that anyone can buy without any prescription. The story actually started in 2017, where there was a paper coming from our lab. Two amazing researchers like Chow and Jesse, they have done comparison between so many different wearable devices. They kind of wanted to evaluate which one are good, which one are not good for health monitoring. And like during that study, they followed one person over time, and they measured heart rate continuously, and they measure like skin temperature continuously. And that's because that's a good thing actually about wearables. You have a continuous measurement of the same person over time, so you can learn the baseline things, the baseline of every physiological parameter when the person is healthy. So when the person becomes unhealthy because of any disease, you can actually find the difference in that signal, and then you can identify that event. What we learned over time is that people are actually different, and the change in the physiological parameter, the effect size is actually different between people. So what you can see here is that for that specific person, when they collected all the continuous data, they found that the percentage of outlier in heart rate and the percentage of outlier in skin temperature, that's kind of just a scatter plot. You can see that most of points are here. And when I say here points here, each point represents 1 day. So all healthy time points are here, but then when you can see all of these different points, those are kind of very outlier. It's not really baseline of that person. That's not the healthy state of that person. And in fact, when you actually associate those days with person metadata, you can find that these days corresponding to different infection days. So that person got Lyme disease, and you can see that those days in triangle shape, those are the one with Lyme disease. Very, very complete outlier from the personal baseline of that person. So that was very encouraging to us, that infections usually preceded by a change in physiological parameter, and it can be detected using consumer grade wearables. And to be able to do that, there was an algorithm that's called change of heart algorithm that Chow developed, and was able to predict all of those days. So when COVID-19 hit us last year, it was exactly like a year, like exactly 1 year now. And we kind of came to that idea, is that can we use wearables to detect COVID-19 early before symptoms happen or not? Because if we can do that, we can actually prevent lots of cases. Lots of people can just stay home without spreading the virus. And remember, like a year ago, there was not that many testing facilities, not many testing kits. It was like very new virus, and we wanted to see if we can help with the wearables. So this is just a diagram demonstrating how SARS-CoV-2 infection kind of goes over time when the person gets infected. So for example, here, when one person gets exposed, he or she may get infected, and then the viral loads start to be high and high and high. And then after some period here, during that period, the person becomes infectious. And the person starts feeling symptom here, meaning that there are a couple of days before the person feeling symptom that the person is infected, and the person can go outside and can just keep spreading the virus. So if we can detect COVID-19 before the symptoms by few days, we can actually save so many cases. And that was the idea. Can wearables actually detect viral infection, specifically COVID-19? And from that idea, we came up with that idea, is that if we have two people get infected, one person didn't know that he or she is infected, they can keep going outside, they can keep meeting people, keep spreading the virus, and then the cases becomes like exponentially growing. The other person, he or she is using MyPhy app, which is app that we developed in our lab, and we collect, and that person has wearable device on him or her, and then we keep collecting all wearables data from that person, and we kind of identify those days when we see any outlier event in the physiological parameter of that person, and we notify that person through the mobile app, and then that person either go and do testing or just at least stay home. Again, we are trying to do that while the person is pre-symptomatic, so person is not experiencing any symptoms. So the way it worked is that we got the IRP approved, we rolled out the study, we actually, we got data from more than 5,000 people, I'd say worldwide, but mostly from people in US. And out of that, we got around 32 people
Hi. I
I
think
know.
it for a bit. Can you just share
Yeah,
this? It never happened.
I
I'm sorry.
yeah, I don't know what happened. So, what was the last slide that you guys
Okay. We're
saw?
talking about the. I mean, if you share the screen, I can tell you. It's the last. I think it's the slide about that. In fact, my PhD one, like when people are using your my PhD app.
Okay, can you see my slide now?
Yes. Yes, this is the one. Thank you.
Okay, so it was this one. Okay, that's great. Um, so so yeah, so I was talking about that. So we enrolled more than 5,000 people, and these people, out of these people, we have 32 COVID-19 positive cases, and those are golden data set. And as I said, golden data set are those people who have wearables data spanning at least 1 month before the symptom start date, and they also have symptom start date, symptom end date, and also COVID-19 diagnosis. So the way it works is that you, like, anyone can enroll in the study, right? And we want to have people who are infected, and we want to have people who are, like, healthy. People are really healthy, and people who are kind of may have different types of disease. So we can also see if we can differentiate between COVID-19 or not. And we collect smartwatch data. So mostly it's activity, heart rate, and sleep. And then we get symptoms daily, how they feel, and what they have eaten. And then also we collect some medical records. So things like heart rate, things like A1C for diabetes, and also if they want to share anything with us. And we're actually we're surprised that many people have actually were willing to share their medical records with us. So that actually helped us to make the study way more stronger. And then all of that happened through my PhD app. And then this is just an example. You can see here, that's heart rate. Then you have the steps. That's kind of daily steps. And then the duration of the sleep. We'll go over all of these in details now. This is how my PhD works. Again, I also want to highlight here a couple of things. Most of the things that we used in this study specifically, many of us were actually using it before COVID-19. It was a matter of getting all of these tools together to just fight COVID-19. So my PhD was developed before to be able to gather many omics data together. So we have so many people in the lab many participants that are measuring their transcriptome, genome, proteome, metabolome, and also their wearables over many years. And we wanted to have one app that integrates all of these together. So that's why my PhD was developed in the first place. And those are kind of the things that usually you see in my PhD, so heart rate, steps, and sleep. And the good thing about my PhD is that it's a device agnostic, meaning that if you have Fitbit device, you can sync it with my PhD, and then you have the data in it. If you have Apple device, you can do the same thing. You can sync it with my PhD, and then you have the data there. Any device, pretty much, we can you can sync it, and then you have it there. And for COVID-19 testing and symptom surveys, we constructed a couple of surveys to ask, have you been tested for COVID-19 and your test result? And did you have symptoms? And then when did the symptom actually appear? And then you have daily symptoms surveys that every day participants in the study, they go and they actually do all of these surveys. That's why the whole study without participants, it actually would never be a study. They are actually the core of our study. So what you can see here, this is demographics about more than 5,000 people that we have collected their data. So on average, we have almost 50% male and female, around 44 years, 44 years old. And this is something also that we can also discuss later on. It's the use of wearable devices. It's more towards youth and younger population than actually older population. So this is something that may actually need to be addressed, although older population actually more prone to all of these different diseases. So if they actually use many of these wearable devices, they can actually monitor their health, and they can act proactively toward improving it. The ethnicity, European, Asian, African American, I would say it's not really It's not really, like equally distributed, but I would say that that ethnicity distribution reflect the distribution of people who are using wearable devices. So definitely there are some work that need to be done on the ethnicity side. And just want to go over the device type. Most of our participants are actually Fitbit users, and I would say like around 1,000 are Apple users, and then we have people using Garmin and Oura Ring and so on. Here is a graph just summarizing the metadata that we collected. So what you can see here, I will try to really summarize most of these graphs so you would be able to read it. There is some basic thing. When you see x-axis, we always talk about symptom onset, and that's a day 0. That's when people start feeling tired or any type of symptoms. So any day before that, that's kind of day before symptoms. That's why it's negative. And you can see in these 32 people, those are the 32 people that are gold COVID-19 cases. So when you see the black bar and then the 2 arrows, that's when the symptom started for that person. That's when the symptom ended for that person, and so on for all other people. And when you see the red X, that's when the person got tested, and it's kind of positive testing. And you can see most of them got tested and positive testing. You can see also a couple of these orange arrows and lines here that mean that prior infection or prior illness. So these people also said that they had kind of illness before the COVID-19 symptoms. And here once we gather all the heart rate of all participants, we kind of developed 2 algorithms. One of them is called resting heart rate diff, which is RHR diff, and then the other one is called HROS-AD. We call it HROS-AD, and this is heart rate over steps anomaly detection. And the way that these work, let's just talk about the first one first. That's the resting heart rate diff. You have day 0, and that's when the person starts feeling symptom. That's the vertical red line here, the dashed line. And then you have the purple line here. This is when the person gets tested. And then you have here in the graph, that's a resting heart rate, but it's a residual, meaning that when you have the baseline of the person, the baseline resting heart rate, and let me go back to the resting heart rate. Resting heart rate is the heart rate when the person is not moving. And the way we calculate that, we get the heart rate. And because we also have the step information, we know when the person is moving. And then we extract the heart rate when the person is not moving 10 minutes before the movement, and then 10 minutes after any movement, and then 10 minutes before the next movement. So that's kind of the resting heart rate. And then you average it, and then you have one measure. So you have it there, and then once you have the resting heart rate, you kind of calculate the residual by subtracting it from the baseline, from the average of that individual, and then after that you get a distribution like this. What you can see here is that most of these resting heart rate are around 0, but in many cases like this here, you can see elevation in the resting heart rate. And the algorithm actually detects this one. So what you can see here in the red arrow here, this is when the alarm actually started, and this is when the alarm shut down, meaning that the person starts feeling symptoms here, but the algorithm were able to detect infection for this person 9 days before the symptoms happen. And this is what we know from COVID-19. COVID-19 has incubation period of almost around 14 days. So for this person, we discovered kind of the infection around 9 days before symptoms happen. So that is a resting heart rate diff. There is another algorithm which also we developed. It's called HROS-AD, HROS anomaly detection. And the only difference between this one and this one is that you take here the HR, the heart rate, and then you divide it by the steps. And the idea behind that is to correct for certain activities. Usually when we are doing some activities during the day, our heart rate increases. And that heart rate increase may not be due to an infection, it's just because we are doing exercise. So we need to correct for that. So that is a metric, that's heart rate over steps. And then the way this works is that it fits a certain Gaussian density estimation, and then you have a threshold. In our case, it's 0.1. So all the cases, like all different events that's more than 0.1, you identify it, and those are the cases that are outliers. So again, for the same person using another algorithm, we're also able to identify the infection before symptoms happen. So that was like very, very exciting case. And let me also go to resting heart rate diff in more details. This is the case, as I was talking last slide, you have resting heart rate pretty much around 0, around the mean, but then you can see here the change, right? The elevation, and then you have the arrow. And what you like, the actual statistic is actually happening like this. It's actually, you have here's average, and then it keeps increasing. And then this is kind of pass, like it passes a certain threshold that we have. And then all of those yellow lines, those are the time that actually the person is getting the alarm. One thing about resting heart rate diff and HRAS is that they have been made offline, meaning that we had access to all the data, and then we were able to make the classification, given that we have all the data. In real time, this is not the case. You want to have algorithms that actually run real time. So as long as you have a new data point from the person, you want to say whether this is outlier or not. But the only reason we made the offline version first is that because we want to make sure that COVID-19 or SARS-CoV-2 infection is preceded by a signal that can be detected using wearable devices. So that was the idea behind those offline methods. And if you do that, if you repeat these algorithms on all different people that we have, the COVID-19 golden data set that we have, you can see these cases. So there is a tiny black line here that is around 0. That is the symptom onset. And then each row is one person. And you can see, when you see those brown lines, that is the resting heart rate diff signal, meaning that for this person, you start seeing signal that is around like 9 days before the symptom onset. And this is the person that I was talking about during the past 2 slides. You have another person here, also like you have a signal, I would say like around 8 days before symptoms, and so on. So for many of these cases, you have like we were able to find a signal before symptom start date. So that was great. For some other people, we were not able to detect it before the symptom onset. Like for this person, we were able to detect it using one algorithm. So when you see the brown, this is the resting heart rate diff. When you see the green, this is HRAS. So either one of them actually gets the result. But in some of these people, like this person, for example, we didn't get it before symptom onset. So we're able to find it, but it was after symptom onset. That also tells us that there are, in some cases, it doesn't work, right? And we want to dig deeper and then see how can we improve those cases. Also, in many other case like this one, you can see also lots of outlier events up to 14 days before symptoms. And you can see also for this person, you have kind of 2 bumps. We call it like double bumps. So one bump right before the symptom onset, and then another bump like around 6 or 7, like 6 or 7 days before the symptom onset. So those are different cases that we have. And if you put all of the data set that we have together, on average, we were able to detect COVID-19, I would say around 4 days before symptom onset. That's relative to symptom onset. And then if you want to make it relative to diagnosis, it's 7 days before diagnosis. And then those are for COVID-19. we have also other illnesses. So many of the participants that enrolled in our study, they also indicated that they had other illnesses like flu, like many other viral infection, and we're able to grab the wearables data corresponding to those days, and we were able to test whether the algorithm can actually predict those infection or not. And on average, we're able to do that in 2 days before symptoms. So the results from here, especially this one, because I would say this is the one that's kind of key, because you want to be able to detect the infection prior to the symptoms date. And in this case, it's 4 days on average in all our population. So that was very good results that we got. And then the next question is, okay, now we know there is a signal that we can detect. How much actually the difference in the heart rate? And this is, difference in resting heart rate when we see the signal. So for each one of these people, you can see here the number on the top of the box plot indicate the difference in resting heart rate. So for this person, it was he or she, I'm not sure. It's eight beats per minute increase in the heart rate. This person is 5. So on average, you can see that's 7 heart rate per minute increase across the population. There's one interesting case here. It's this person. It's 62 62 beats per minute increase. So we were kind of thinking that this may be just maybe the data wasn't right, maybe something was wrong, but we tried that many different times. We actually validated it, and it was actually true. So it's 62 beat per minute increase for that outlying event. Next question would be about the steps. Since we are collecting all the information about different lifestyle, like steps and sleep, we tested different thing. So here what you see on the graph is that the day 0 here is a symptom date, right? Symptom start date. And then each row represent one person. And when you see a star, this is the day when the algorithm, which was resting heart rate diff, identified the infection day of this person, or kind of the alarm day. So what you see for the first person here, you can see here it's -5, meaning that for this person, we were able to identify outlying signal 5 days before symptoms date, right? So we got all of these stars from the previous algorithm. But then in case of steps here, what we ask a different question. How about the steps profile before the detection day and then after detection day? Meaning that does the activity profile before our detection is actually different after detection or not? So we tested that for all of these people, and we find that it's significantly different. So people are walking less, so it's less step count around COVID-19 onset detection. Again, there is very, very important note here that has to be made very clear. This is not, this is pre-detection versus post-detection. It's not pre-symptom versus post-symptoms, because we all know once we feel tired, we pretty much stay at home, our activity profile would be down, right? So that makes sense. But what we are doing here, it's not around 0. It's not around symptoms date. It's around detection date. So meaning that even when we get infected, like SARS-CoV-2, we still don't have symptoms, and at the same time, actually, our activity profile is actually going down. It's going down a very subtle level that we may not even notice it. But if we have a wearable device on us and we have the algorithms on it, we would be able to detect it. So that's very, very powerful thing from the wearable devices. Another thing is about sleep. We did exact same analysis on the sleep. And here we measure the duration of sleep. So Fitbit and many of the wearable devices, they measure sleep by measured by kind of integrating 2 different measures, like the heart rate, which is measured by PPG sensor, and also the motion, like the steps, which measured by accelerometer sensor. And using those 2 sensors, you can actually get when a person is asleep, when he or she wakes up in the morning, and then you get a sleep architecture profile. So you get how long the person spent in the light stage, in the deep stage, or in the REM stage. For that analysis specifically, we focused on the total duration of sleep per day. And again, we measure the change in the profile before detection and after detection for each person, before and after. And you can see it's very significantly different pre-detection versus post-detection. And it's usually like it's more. So people are sleeping more after getting COVID-19. Again, similar to the previous analysis, this is not pre-symptoms or post-symptoms. It's pre-detection versus post-detection. The other thing is symptoms that we collected, symptom dynamic and severity over COVID-19 illness actually relates to the detection, to the detection period. So what you see here is that this is one person that we have, and like when you see the red arrow here, this is a detection period. There was like elevation in the resting heart rate. And you can see the first black line here, this is a symptom onset, and the second black line, this is the diagnosis date. If you go up, those are different metadata that we collected about this person, right? You can see here, the one on the top here, that is the temperature. So from here, the person start feeling, here it was like feeling okay, that's a green, but then start to feel overtired, but then here start to feeling, like really overtired, and then the temperature start to increase. And all of that correlate very well with our detection. Again, another support for the detection that we have. And we have seen that for many people that we have in the study. Okay, so up to now, I was talking about the offline algorithm. The main purpose of developing that, as I mentioned before, is just to demonstrate that and actually assess whether COVID-19 is preceded by elevation in heart rate or not, something that we can detect using wearable devices. But in real life, we actually want to deploy that in real time, meaning that everyone would have their, like smartwatch, and they would be connected to the mobile where they have the MyPhy app. And then when we take the data, we process it, and then if there is any elevation in the heart rate or any physiological parameter that we have, we'll send it to the mobile app, and then it will trigger an alarm, and then people can stay home. So that's real time. The difference between real time and offline is that in real time, we don't have access to the future data. We only have access to the historical data and the current data point. And we have to make inference based on the current data point. So this is those are a couple of examples here. So what you see here is that this is the red line here is a symptom start date, and the purple line here, that is a diagnosis date. And what you see here, it's a Q-sum statistic, which is another metric that we employed to be able to accumulate the difference across many days. And then once it passes a certain threshold, would trigger an alarm. And this is what you see here. So it's there is a signal. It's not very passing the threshold. And I can talk more about the threshold, but it's just in brief here. It's here, it's not passing a threshold, but then it keeps increasing. And here it passes the threshold. So there is alarm. The alarm goes off here. And then after that, you see, you can see the peak. It's going up and then going down. And then this is another alarm here. So it's going here, and then it passes certain threshold, and then it's going on. So that's one person. You can see for another person, you can see multiple alarms. Again, this person also, this is a COVID-19 case. You can see alarm before it. This person, you can see the peak corresponding to the COVID-19. You can see the alarm going on before it. So one thing that we actually noticed in our data set is that during the holiday, things like, I would say time during late November, early December, there is a peak. And we don't know why is that happening, but we have seen it in many people, and we call it holiday pump. So it may be something happening during the holiday, maybe different lifestyle Maybe people are traveling, people are doing something very extreme that triggers the alarm. It may be infection, it may not be infection. We actually don't know. So that is one thing. Another thing that I also want to talk about here, I think maybe let's talk about it here in this slide. It's in real time, you may get alarm not just because of COVID-19. And this is one important note also that needs to be made. Any differences in physiological parameters, it may be due to infection, but it may be due to many other factors, right? Maybe a person is doing extreme exercise, traveling, drinking, doing anything else. So we want to be able to differentiate between COVID-19 or infection in general and any other situations. So this is an example here. So what you see here is each, like the x-axis, different people, and then you can see the alarm count. So for each person across so long period, the person get many alarms. So you get alarms after infection, and you get alarm before infection. I mean, like after infection, I mean like before, like during episode of infection. And you can see that the number of alarms around any infection, it's actually way more than kind of other alarms that the person may get, either because it's just false positive or because there is something going on, but we just don't know. Like we don't have a gold standard data to be able to validate it. So that's one thing. The other thing is we also want to see whether the online version actually improves, like, or how it work compared to the offline version. So this is the online version and this is the offline version. And each point here is like indicating one person. So for example, this person, you get an alarm 15 days before COVID-19 if it's offline, and you get it 10 days before COVID-19 if it's online. And you kind of see a good correlation between the online and offline, meaning that all things that we found during the offline can actually be transferred and also be applied during the online. But there is a big distinction here, is that in the online, as I said, you would get many alarms just by chance, right? Just random, because of many things that we can do that can affect physiology and affect heart rate. And we want to differentiate between those. So you can see here, those are different alarms that you get during COVID-19. And those are from COVID-19 positive cases. So this red one is during sickness, green one is post-sickness, and then the purple one is pre-sickness. So it's kind of like a couple of days before symptoms. And then this group is potentially healthy people, meaning that we have wearables data from around like 100 people who haven't reported any symptoms. They said that they were healthy. They didn't have any COVID-19. They didn't have they didn't experience any symptoms. And the way we call them potentially healthy, because they may not be healthy, right? They may actually get infected, but they haven't experienced any symptoms. So that's why we call this group potentially healthy. So when you see the alarms from this group, it's like this. And then when you see the alarm from the COVID-19, it's here. And here what we are comparing is the alarm duration. Remember when the alarm goes off, when like there's a peak and then it keeps going on, it's we kind of want to see the duration of the alarm. You can see the alarms that's coming from COVID-19 cases, it's way longer, right? Meaning that the peak stay there for a long time. But alarms that you get by chance, it's pretty much something instantaneously just going away. So that's another thing that we can use to be able to differentiate between true alarms and false positives alarm. The other one is peak height. Remember the Q-sum case, that's kind of, there is a peak and the peak goes high to a certain level. The peak of the level, the amplitude of that peak is also different between COVID-19 cases and potentially healthy cases. So again, another threshold that can be put to be able to eliminate lots of these false positive alarms. So what I've talked up to now, this is a work that we published a couple of months ago in Nature Biomedical Engineering. And what I want to really stress on is that the data, all the data are publicly available. So all the data, all wearables data, the metadata, and we have anonymized the data. So anyone if you guys can just go ahead and download the data, can work it, and then can develop new algorithm, and then can test it, and then we can see if we can improve or not. The new thing that we are working on nowadays is phase 2. And phase 2 is online and real-time detection. So the online detection that I was talking about before, it's online in a sense that how we are testing it, but we have the data. It's not like we are testing it on actual people. It's we have the data, but we are kind of blinding ourselves from the future data, and we are doing the inference on the current day. This one is actually you want to deploy it on so many people, and this is actually what's happening nowadays. So that's phase 2 of this project. So we like recruit people, collect heart rate, steps, and sleep, and then you get the Q-sum statistic. That's kind of the outlying resting heart rate. And then for these cases, it's kind of there's a certain elevation, so that we call it yellow alarm. Right? It's elevation, but it's not really strong elevation, so it's yellow alarm. And then here it's normal, so it's green alarm. It's okay, like no problem. But then you have a strong alarm here, and this is a red alarm. And this is once we send this to, like once a person get this alarm, it's kind of stay at home, go test, and then confirm whether this is a true value or it's just something else. And then we take it, we take it into the system, and then it helps the training again. So that's what's being done now. And there is updated version of the study app. So it now supports iOS and Android for Fitbit, for Garmin, for Apple Watch, for Aura Ring, for Motive Ring, and soon for Sensomics watches. This is how the app looks like nowadays. And if you want to be part of the study, please go ahead and go to this website and just be part of it. We have like thousands of people now part of the study, and it's actually getting a real-time alarming during the days. So just to summarize here, it's 81 of the COVID-19 cases associate with alterations in heart rate, steps, or sleep. And 84 of those are detected by both algorithms, so the 2 algorithms that we developed. And then there was one part that I didn't talk about, which is we kind of divided the positive cases into 2 or actually 3 groups. So the first, the 2 group is the people who only have 1 peak, and then the 2 groups, the group number 2 is that group of people have 2 bumps, 1 bump before the symptom. And then we have 63% detected, 63% of the people, we detected the elevation before symptom onset, and that's real time. And then the phase 2 would be deploying it real time, and this is what's happening now. This is very teamwork. Lots of work has been actually put here, I would say, for so many months. So I want to thank so many people from the Snyder Lab, people from Stanford Emergency Department, and Fitbit, Empatica, Garmin. They worked with us a lot. They gave us, we had really great collaboration with them, and also the funding agencies. But most importantly, participants. It's without them, it's this tool actually won't be there. I also want to stress on something, that what we have been working on specifically for COVID-19, I would say now COVID-19 hopefully will be gone forever, but also that this framework can be used for any future pandemic or just keeping, monitoring the health for any other infectious diseases. So the framework that was developed is very, very powerful. And I would say it's in a good shape now to be used for in many other diseases. So this is my email. So if you need anything, please send to me. And again, thank you so much for listening.
Thanks, Emma. That was really wonderful talk. That was really insightful. So we have some questions here. So
Let me see.
So
Okay. Do you wanna go over them?
yeah, sure. Okay, yeah, I can go over them. Sure.
That
So
would
I
be
guess
great.
the
Yeah.
first question was about, like, okay, data privacy. Like, I guess.
Big issue. Yeah, I can say this is one thing that we took it seriously. We as a group took it seriously. Stanford is actually taking it very seriously. We had to pass through many rounds of uh, revision for the MyPhy app, for the data, where we store the data, where we process the data. I mean, something you can see over the slides. It's actually there is no patient ID. It's all of them are randomized IDs. So, like a couple of layers of anonymization. So that all to keep the data private. I can say that my PhD app actually got one of the best awards at Stanford in terms of privacy, and I have to really give shout out to Amir and Arash who have done amazing work developing the app and really thinking hard in all different cases of privacy. They are attacking it from different angles and make sure that the data doesn't follow through that test. So yeah, so it's something has been taken care of.
Yeah, that's very cool. I will download the app. I'm very curious to,
Yeah.
check it out.
Yeah.
Okay, the next question has been that how are you dealing with the false positives or, true positives and those
Good
stuff?
question. Yeah, so that's a very good question. So dealing with it in a couple of ways. So the last slide that I presented, the one that showed the peak, the peak height and the peak duration. If we gathered enough amount of data from enough amount of people, you can actually learn a distribution that can differentiate between COVID-19 cases, actual COVID-19 cases, and false positives due to any extreme lifestyle. So that can easily take care of it. Another layer we are also doing is that once we send alarm to people nowadays, is that we also collect the results. So once we send the results, it's kind of ask people a couple of questions. Are you doing extreme exercise? Like we ask them, are you doing extreme exercise? Are you, watching scary movie? Are you doing something abnormal? And then if not, okay, can you go do testing, COVID-19 testing? And then once you do testing, can you report the results? And we take all of this information and then we put it back into the system, right? To be able to train and to be able to identify the different layers between the actual signals and the signals that are just false positives. So I can say by time actually the algorithm is getting better and better. Um, so yeah.
So, what about like in the online tracking? So, do you like, ask feedback during that time as well?
Mhm. Yeah. So for when it's kind of like once you receive a message from any vendor on your mobile, and then it tells you like yes or no, right? So it's kind of sending something like that, and then saying, okay, we detect outlying signal. Is there anything that you are doing extreme or anything abnormal? And then we give a couple of options, and then maybe another options like kind of other. And then it's kind of it's very interactive.
Okay.
People like it, and we loved it. It's kind of it makes it easy to gather information. And I mean, the whole purpose is that you don't want to have a system that, yes, it can, I mean, it can prevent spreading virus, but you don't want to have a system that's kind of just keep giving you alarms, and many of them are false alarms. You don't want to have that behaviorally. You don't want to have that. So we are also working with people on what is the optimal number of alarm that people can tolerate per year, even if they are false alarms. And then we are trying to make the threshold kind of to be within that limit. It's kind of more of design aspect um, that we're taking into account as well.
Got it. So, yeah. So there has been another question is that how will you distinguish between like a love, heartbeat, etc. and disease? I guess will it count as a similar question or
That's a great question, I would say. It's up to now, we are not actually able to differentiate between SARS-CoV-2 infection and other infections. And I would say it's because most of them, I mean, from physiological aspect, most of them would be the same. Um, so we are not expecting, I mean, we were hoping to be able to differentiate between them, but we didn't have enough support actually to differentiate between them. Maybe when we collect more samples, when we collect more data, we would be able to do that. But right now, we are not able to do it. Yeah.
Okay. Um,
But
okay.
I
So
also want
I
to
have
say
one
something
question.
here. Yeah,
Sorry.
I just want to comment on that. It's even if we even if we don't differentiate between SARS-CoV-2 and other infections, just by saying that the person may have an infection by itself is actually a knowledge, right? Like, what's the difference between person having a flu and going outside spreading flu and person going outside with COVID-19? Yes, maybe the danger is different, but still, it's most of them. Like, when you have something, we want people to stay home and take protective measurement.
Got it. So there's been one question about, like, how what was the like how about COVID-19 versus other similar diseases?
So that's
I guess it's
yeah.
similar.
I think that's what I just
Yes. Yes.
replied to.
Right.
It's like right now we are able to detect other diseases as well, but we're not we're not successful in finding different signal that can differentiate between SARS-CoV-2 and other illnesses. And when I talk here about illnesses, it's mostly infectious diseases. Still, we haven't tested it in other, I would say, chronic diseases, right? Because most of chronic diseases, it take time to build up. It's not like infectious diseases. You get you got exposed to a like you got exposed to a virus, and then you start feeling symptoms, I would say, after a couple of days. I mean, SARS-CoV-2 is one of the longest in terms of incubation period, like 14 days. Other viruses is like 3 or 4 days maximum. So that's the case.
Okay. Well, I had one question. So maybe you have
Yeah.
maybe you had like said it already in the presentation, but I may have missed. How like where are you getting this data? For instance, I mean, I know that you're getting it from the apps, but are they the ones who have just downloaded the MyPhD app, or is it from the hospitals? Like, where is the
Anyone. Yeah, that's a good one. It's actually, I can speak more about the challenges there, but let's say you're at home, you have your device, you just go to the app store if you have iPhone, or you go to the, I think, Google Play if you have Android, and then you write My PhD, you download the app, and then you sync your watch with the app. And then once you do the sync, and then like once you do the sync, you also can consent to be part of the study. You
okay?
can answer a couple of questions like the age, gender, and all of these questions, and then you give consent to like to share your wearables data. And you have actually the choice to share just heart rate, just activity, just sleep, like whatever you want. And then once you do that, we would be able to have access to your wearables data, and then we run it automatically over the algorithms. And then once we detect any signal that's kind of in your app, you would be receiving like a signal. Okay, now it's yellow alarm, now it's red alarm, things like that.
Got it.
So it's very streamlined
Okay.
now.
Got it. So there was one, in your presentation, you had mentioned about holiday bump in the slide about the online, real time detection. What's that like? Is it
You mean the holiday bomb? It's something that we're thinking that maybe it's an issue in the data first, but then we have seen it in many people, and and the hypothesis behind it is that maybe people during holiday, they either do something extreme, or maybe they kind of do something that's not normal, and then they got infected. It just, we won't be able, I mean, like with any of these alarms that we get, that even we are saying they are false alarm, they may actually not be false alarm. They may be actually true alarm. It's just we don't have data to say whether the person was infected, or there's something going on, or not. But that phenomena of holiday pump, we have seen it in many people. We still don't know why it's happening. And that's, I would say, the only thing that will make sense if we keep collecting more and more good quality data. And again, that's a good point to say. It's collecting good data, collecting the right data is super essential. I can give a couple of examples if you have a couple of minutes here. For when we started the project, we had the idea that the best signal that we can get is during sleep,
okay?
because during sleep, people pretty much won't be doing any activity. So you kind of take out all, different environmental variables. People won't be, exercise, like anything. So it's people won't be, eating crazy food or anything. So you would get the best signal during sleep. But what we found is that many people, especially Apple user, like Apple Watch users, they actually don't wear the watch during the sleep. And
Yeah.
it's mostly because it's a design problem. It's the watch battery actually lasts for 20 or 18 hours. So many users actually charge it during night. So although the watch can measure it, it's
Yeah.
people don't do it because it's a battery issue. So things like that. So you may design an experiment about the sleep, but then turns that it's not the best thing. And also, like, if you do it about the sleep, it's you would only get the results during the night, but you're pretty much wasting the whole day, right? We wanted to
Okay.
have the highest resolution possible.
Got it.
Mhm.
Yeah, even I don't wear it during the night.
Exactly. Yeah.
Okay. So thank you so much. I think we don't have any more questions. But yeah, that was any other questions? I don't think so. Okay. Thanks a lot, Emma. That was really
Well,
wonderful talk. I will definitely go ahead and look into the app and the data set as well. Thanks a
my
lot.
pleasure. Sure, sure.
Yep.
Take care. Thanks.
Yep.
Bye.
Bye.